or breast cancer. And just walk us down the path.
Well, I haven't reviewed in depth the justifications, the benefits and the costs of those alternative procedures. I only know, in general, what we all know about them. I did try to get on the internet and find a little information. For example, what percentage of adult women are actually getting mammography every year? It's a highly politicized issue. Anyone here have any idea? It's been politicized. Komen Foundation says it's 80 because they're selling
the American
fundraising.
Cancer Society says 35% of those who are qualified or should get colorectal screening are getting colorectal.
I think it's probably even less than that for colorectal because there's a big impediment there. Just look at that too. and you're talking to men mostly. There's probably a much higher percentage of women that get annual pap smears. But in fact, I wasn't easily able to find a reliable number for any of these things. And it's important. It's one of the variables in my equation that would allow you to estimate exactly how many events we might prevent. These are numbers we ought to be able to get some kind of a handle on. I would think that we ought to be at least as effective in cardiovascular screening as we are with these other procedures, because there's more involved in getting a pap smear or a mammogram or a colonoscopy than there is in getting a shape screen.
Well, there's one quick comparison and contrast is, unlike cancer, where once you detect, even at any level of severity, you have a lifespan of weeks, months, or maybe even years to do something about it. Where in terms of coronary attack or heart attack, we all know at least 40 to 60%, depends on the first symptom is sudden cardiac death within an hour. You don't have any chance to do what you wanted to do with it. If there was one choice for screening for my body, I would want to have that screening for a disease, when I'm at the age, for a disease that kills me right away. Now, how can we translate these two numbers?
You're asking me about emotional justifications for convincing people to do this, and I agree with you, the marketing of the strategy is critically important, but I'm not here to talk about the marketing today. I'm here to talk about justifying the proposal in its first place in terms of how many lives can we expect to save, how many dollars would we have to spend to do that. We have to have those basic numbers in place, and if they're not very good numbers to convince other people, then we need to change the proposal to gerrymander the numbers into something that we can sell.
You brought up the shape equation. Would you mind walking us through the shape you want to write or
not off the top of my head.
No, but we have your numbers actually.
If you got it there, I can write it down for people to see. Yeah.
I think this is the second one. Early, do you have the proposal?
Well, I have it inside in my bag.
Okay, let me get your bag.
While he does that, I have a real simple question. If we can assume that, like in the cancer arena, that only a third of the population is actually going to get the test, can't we assume that the real cost is only going to be $1.8 billion, not 5.6?
No. In fact, I'll go through the numbers with you. Thanks. I'll give you the numbers that I'm estimating here, and we can argue about them. There's nothing sacred about these numbers. I did some research to come up with estimates, but I don't have standard deviations, and I'm perfectly happy to hear other alternatives. Here's the equation that I came up with. Everybody read that? Okay.
It looks like Chinese to me.
N times F times another F times another F times another F times another F, all multiplied together. The N here is the number of prevented atherosclerotic events per year. And it is a function of these 6 numbers.
Defined as hard events, soft events?
No, I'm defining this as hard events. If you want to change that, you can change that. I actually have an estimate for N. The estimate for, I'm sorry, I'm going to calculate the estimate for N. It begins with this number here. That is the total number of events that are occurring per year. Now, I define them in terms of hard events. But if you wanted to change that number and change the definition, that's fine with me.
It seems to me that perhaps we should, because a substantial part of the costs are attributed to soft events like revascularization of one.
Fine with me, there's no should involved. There's no right answer. It's an operative answer. If you think that the benefits are better derivable and justifiable by including the soft events, but then all these numbers will change in addition. So you've got to also have estimates for the new condition. But that's fine with me. There's no right or wrong here. I'm going to show you what I did, simply because it was the easiest thing to do, not because it was the right thing to do. Okay? First number, how many events are occurring in the population per year? Well, the AHA gives us estimates on that. It's $1,065,000. 565,000 new infarcts every year, and 500,000 new strokes every year. That's all I counted, because that's all AHA counted. The deaths are included in that. These are the new events. Some of them died, some of them didn't, but we want to prevent both the fatals and the non-fatals. So that's an operative number, okay? Now, would you rather argue that number as I go down, or shall I just go through the list of them first?
Yeah, let's go through
Go through the list. Okay, fine. The next number, I don't want to misspeak, so I'm going to refer to my notes here. The next number are the fraction of candidates in the baseline population. Now, what is the baseline population upon which this is based?
The number of first events.
Yeah, the number of first events. What is the baseline population? Well, reasonably, it's the adult population of the country. 80 million people. 78 million to be exact in the 2000 census, but it's more than that now. It's growing every day. It's about 80 million people. There are about 200 million people, 200 million adults in the society.
Attract people with known disease.
No, that's a fine distinction. We don't know the number of people with known disease. No, we really don't. If you look at the statistical abstract of the United States, you can't really find that number. I've done that. I've tried to, and I can't really find it. But people talk about, well, there's 5 million people out there with ischemic heart disease, but I don't know where they get these numbers, because you can't find primary sources for it.
Well, Enhance has the data. You know, every 5 years they do this representative sample from the United States.
12 million according to...
Yeah, 12 to 13 million.
Right, but what's the primary source of the numbers?
Yeah, well,
because NHANES published an article that says it.
Yeah,
you can't go back and find.
We can talk
No,
about
the
that.
NHANES is on the CDC website. The whole database is on the website.
Understood. What I'm saying is I don't really know the number. If you want to subtract
Yeah, we can subtract
X
that.
million people
That
from
doesn't
80
change.
million, it's relatively irrelevant.
See, the way that we started for SHAPE was that 78 million I took from census 2002 minus 12 million. 65 million is people who are not sick by
But
cardiovascular.
I could argue there's no reason to subtract them in the first place. The fact that somebody has a previous myocardial infarction doesn't exclude it from having a new event.
Oh, no, it's not, but the
Screening is...
No, you might still
Yeah,
have to, if the goal is if the goal is to identify those that are due to have a new event.
George, let's
We want to hear what you have to say, though, because I think we could fight about numbers between now and 8 a.m. tomorrow.
Agreed.
So let's just hear what you have to say, and, you know,
Okay,
just say it's
yeah,
10
that's
million, it's
fine.
10
Yeah, we
million,
can
and
play with
it's-
those numbers. Yeah, it's a
I mean,
bit-
it's,
That's
yeah,
fine.
We'll fight forever.
Okay, FC, the proportion of people, I based upon a very simple 80-20 rule, and the justification of it is in the writing. 80% of the events occur in 20% of the population, and that rule is generally true no matter what you're looking at. 80% of X occurs in 20% of Y. Pareto's rule. So FC, therefore, is 0.8. That's what your primary screen is going to be. Your primary screen is going to identify 80% of these events in whatever population. As an example, if you would take 20% of the total population, the 200 million people, through risk factor screening, you could get them down to a population of 40 million people that contain 80% of these events, about 800,000 events. You could make other cutoffs on risk factors or other cutoffs on your primary screen. Your primary screen currently is women over the age of 55, men over the age of 45. That's 80 million people. If I were to then do a risk factor analysis by Framingham and simply select those with above average Framingham risk screens, I've reduced the 80 million people down to 40 million people by definition. And in those 40 million people, I'm going to have half of the 800,000 events or 40,000 events, because they're about equally distributed within that population. So I don't really care what your primary screen is, but the primary screen has to be something along the lines of an 80-20 split of the total population.
Well, this 80-20 spread is the sensitivity of your test?
No, it's Pareto's rule that whatever decision criterion you decide to use on the bigger population, you will choose it to select 80% of the events in 20% of the population.
But I don't know how you go this way, because we say if you have a target population and you subject them to your screening test.
I haven't done your screening test.
Oh, you haven't done it?
I haven't even done it yet.
Okay.
They haven't walked through the door yet. I've just got to get this number down.
So you're saying you are losing by chance 20%?
Well, let me give you the analogy. In acute coronary syndrome, most of the events occur in high-risk individuals.
Yeah.
How many are there in high-risk individuals of the acute coronary syndrome population? 20%.
20%, yeah.
That's it.
true.
That's what it is.
Okay.
Yeah. So it's a gestalt, very simple decision rule. It might be anybody with an above average risk factor screen. Or it could be an age and sex cutoff. Okay? The next variable, FS, the fraction that you will screen. You now have this population. How many people are you going to screen? You're going to screen everybody? No. No. Even if you put the call out, even if insurance paid for it all, you're only going to capture a portion. We agreed that even though everybody's supposed to get mammography, that only maybe 30% do, right? So there's going to be a much smaller number who actually get screened. I'm going to say, optimistically, you get to screen half of the candidates.
And the reason we don't screen the other half is just
They don't
reality.
show up.
Yeah.
You ask them to come in, and they refuse. In the same way, people don't get mammograms and pap smears and colonoscopies. All right? Now, maybe you could increase that. For example, if they had an incentive to come in, if they were told that they would get a discount on their health premium if they got annual screening, then maybe you'd get a few more. If their employer said that they can't come back to work unless they get it, you might get a little more. There's ways to build incentives and to change the numbers, but for this purpose, I'm assuming you'll get half. And it's fine with me if you think differently. If you do the screen on everybody, the screen here might be, let's say, a coronary artery screen. What percent of them are going to screen positive? What percent are going to be detected? Well, you people tell me you're perfect.
Speaking to the opposite.
If you're covered, your sensitivity,
Only the people in this room are part.
your sensitivity is essentially 100%.
What's the question you're asking?
I'm saying, what percentage of people who have disease will you detect with your screen? 100%. I'm being optimistic. You want to make it 95? I've been told by others it's 100. Actually, Mark tells me it's
99.8%.
99.98%. Call me a liar.
My population is high risk, I cannot tolerate that 10% risk. I
got to
Obviously you can max it up to 100%, just reduce your pressure.
If we want to change it, we can. I have a calculator in my bag. 100% for now.
That's
They
really
get
a
the same.
sensitivity.
Yeah, it's a sensitivity.
It's a sensitivity of whatever.
Whatever test.
What percent of those detected on screen to be at risk will be treated?
Will be treated.
Will be treated.
Not realistic now.
It will depend on the extent of the risk that you determine.
No, it doesn't.
Yes, it does.
No, it doesn't.
It does.
No, it doesn't. We're talking about.
It does.
We are talking about 80 million people. So, yes, it depends within that population. We're talking about
No, he's
population
talking about
averages of
societal
huge
factors.
numbers. Only the average counts.
So it's not 100%.
Of course it's not 100%.
He's bargaining for 20%.
Let me ask you.
You have a patient with a positive test.
Yeah, but a score of 1 in a 60-year-old man does not warrant treatment. It's a positive test, but it doesn't warrant treatment.
I'm sorry.
We're risk stratifying the patients according to the extent of the
Yeah,
disease.
he's talking about getting an average.
20 to 30%.
What's not
What?
one?
Wait a minute, you told say, just a minute, I'm going by the shaped proposal,
Right.
all right? You said, within the proposal, within the algorithm, that if they have a calcium score greater than 0,
Yeah.
they are detected and therefore enter into a therapeutic.
But they don't all get treatment, though.
They do.
Because the risk is low in those with very low scores.
Just a minute,
Harvey, we do have.
just a
We
minute.
don't have drug treatment.
Well, if they have risk factors,
We still don't have drug treatment for patients who have a very low score.
You're perfectly happy.
Okay.
I'm perfectly happy to have you say, I won't recommend treatment in the low-risk people and will treat the high-risk people.
Right.
I only want to know
Okay.
the average.
average number.
You have screened,
30% is pretty
you have
good.
screened a population of 20 million people here.
20 to 30%.
20 to 30%. I agree with you. I use a figure of
If you
30%.
chose the 50th
It will
percentile,
be half.
it would be half.
Right.
The number half makes more sense to me.
All the more reason for a
But
percentile.
there are
Makes
a
more
lot of,
sense to
there's a
me
lot
as
of
well.
people that don't get treated, that's the reality.
She's talking about reality.
Okay, we're doing reality.
You write a
Dumb doctors and
you
smart
write the
doctors.
report and say they're.
Multiply 50% times 50% compliance, you're at 25%.
Okay, all
All right,
right.
so say 25%.
30% is realistic, 30% is
All right,
realistic.
30%, 25% is the right range.
They should be fair.
All right, so this is the number of people that are going to be treated effectively. This is consistent with published results, for example, in lipid-lowering trials, in terms of the number of people that are brought to guideline after it's decided that they are candidates for treatment. So again, every one of these numbers is only a candidate for inclusion. You're perfectly welcome to change it. That's the number I'm using. And now, given that you are effectively treated, what is the likelihood of your having an event?
Depends on the treatment.
Among effectively treated patients,
60%.
60?
The best that you can do with statins is 40, so it's 60%.
Well,
What's
what's the patient being treated with here? Are they just being treated with
Best I can do.
statin? No.
Aspirase and statin.
Sure.
80% reduction in events.
Yeah, well, I use 70%.
Wait a second, George, you're not talking about a reduction of events, you're talking about the absolute amount of events.
The reduction in events.
Percent reduction.
The
If
percent
they weren't
reduction.
treated, if they
I'm
weren't,
going to calculate the number of events that
Relative
occur.
risk reduction.
I'm asking you here.
Seventy or 80.
Yes, the figure
Yeah.
is
70 is fine.
70% event reduction.
With current, with statin monotherapy.
No, statins.
with our arsenal of drugs.
Event reduction?
Statins,
Not very high.
Yeah.
That's dream world.
Wait a minute, if you look, it's not a dream world.
But that's okay.
Yes, it is, just a minute, come on. Yes, it is the dream to achieve that in a large population. But if you look at the randomized clinical trials, the large trials on lipid level,
30%.
if you look in addition,
Harvey.
listen, if you look at the event reduction in the people on ACE, on aspirin, on beta blocker, and on statin, the event reductions in several large-scale trials is 70%.
Is that real or theoretical?
It's
Just
real.
by
It's
adding
not,
the
no, it's not
numbers?
theoretical, it's the real number
Harvey,
in
in
the
the
trial.
4S trial, if you're on an aspirin, any blood pressure agent, and a statin, 70%.
Yeah,
70%.
And this is very much like what the Walt's paper on polyp.
Now, I grant you I'm being optimistic. I grant you that. It may not be the case.
Just like
But
taking
the
all
higher the number, the better it is in your favor. So you shouldn't be wanting to be arguing me lower.
Go on, Arnie.
Okay.
No, George, wait a minute.
Yeah.
We have trials of HOPE, Europa, and the PEACE trials, where you had 70 to 90% compliance rate with statins. There were an aspirin, and there were an ACE inhibitor, and I think 60 or 70% compliance with beta blockers. These are patients with chronic stable angina. There, even that high-risk patient population, the risk reduction did not exceed 40%.
It's okay with me.
So,
You want to change
okay,
it?
if you really want to go with evidence, 70%.
0.7 post
I heard,
I wouldn't, okay, we're not going to discuss it, but that is not a representative of SHAPE population.
You don't want to know the shape.
let's talk about clinical trials. I'm showing you the numbers that I used in my example. You're welcome to redo the calculation up here with your own numbers. In fact, you're more than welcome. I
We
encourage you
can
to
talk
do
about
it.
that, but I think we
All right.
have our arguments.
In any event, using these numbers,
These are asymptomatic people.
I come up with 89,000 events prevented.
There's higher risk.
89. But you did,
Per year.
Let's go.
89,000 events prevented.
didn't you use an FT of 1 rather than 0.3 in your calculation?
No.
30% treated.
Yeah, 30% treated.
I thought you used a 1.
The one problem that's really problematic is that sensitivity. Because if you're talking about patients over 55, 60, and you're talking about a score of 1, there's no reason to scan them in the first place.
Everybody
Because
has.
everything to have a score of 1. What you go back is, if you treat the top 20% aggressively, that's going to be responsible for 80%.
That's why.
Are easier to manipulate and really in real life practice and gain a better outcome.
Well, that's,
Which one, okay,
Sensitivity for each one.
improving which one of these is more cost effective or effort?
FT,
That's what it
that's the
is.
compliance number, but in point of fact, it is very hard to get patients to comply. So, yeah, maybe, that's certainly a candidate, and it's one of the low numbers.
Yeah,
It's
and
the
let's
lowest
say,
number.
to answer Archer's comment, let's say we take this from 9.9.
It's going to get worse.
It's gonna get worse, but not as much as if you take this one from, if this one, it was 40%, that means you do a little effort in increasing compliance, you can cover about 0.9.
Yes.
They're more than compensated.
Oh, yeah.
Yeah.
Actually, more than.
More than 30%. Yeah.
You're covering it by 33%.
We could do sensitivity analysis on each of these.
So I wanted to comment that this is not a major concern. We talked about this, that we in population age 45 and above, or age 45 to 55, a score of 5, 10, or 20, or 50, or 100 is not equal to from 70 to 80 and 85. We discussed this, and we actually have more problem with IMT than coronary calcium. At least for coronary calcium, we have populated data, but for IMT, we still don't have those percentile to go by. But my point was that we can address that with manipulating other parameters in this. Now, George.
Well, one thing you could do, for example, is go to lipid clinics and find out what's the compliance of therapy in a lipid clinic where you got basically a dedicated nurse bending over backwards to help the patient. If they're getting 50% compliance, then you can't expect to do better than that.
It's much higher in patients who've had a calcium scan.
That's debatable.
I don't think so.
Wait, he said,
Except in the Army.
Alan Taylor is here. He can answer that.
But we're going beyond the point. The point is you get an upper and lower bound of an estimate here. I'm going to say it's somewhere around 90,000 patients a year, maybe 100,000 patients a year, the events that you would prevent. That is less than 10% of the total number of events. That's the best of your yield in my estimate. So you've got to be realistic. Our yield is going to be something in the range of 10%. You want me to be grossly optimistic? 15%, 20%, but still the minority of the events that are going to be prevented by this program. I also worked out the cost, because there's a cost to each of these steps. Well, not to each of them. There's no cost to this, because that's simply the interpretation of the test, and that's part of the cost of doing the test in the first place. But if you run through the costs, if you subtract the benefits from the costs, you can wind up with an estimate of how much money must be spent in order to achieve that outcome. And the amount of money that I got was $5.6 billion with a B. That's what this costs. It is not cost saving, at least not based only on the hard costs of the events. Now, if you calculate it in, the savings attributable to employability, quality of life, reduced disability, etc., it may be that you can increase that. Quality of life actually probably goes down here. These are asymptomatic people that you're going to wind up putting on pills. So it is very unlikely that you can expect to improve their quality of life. Much more likely you will worsen it. Not much, a little, but you're not going to get a benefit there.
It's very sensitive.
I understand.
That is huge.
We have to be realistic about each of these factors. So I don't know that you're going to reduce the cost by factoring in what the program is currently structured to cost. If you don't like that, change the numbers and
Based upon what cost?
based upon the cost for every step. The cost of
screening.
Fits so nicely with the discussions you need to.
How many of you know the story behind the
That are borne by payers, patients, that are by everybody together. And it's not, the costs aren't just borne or felt to be borne by one strict sector. And so within that, we then have to define our model from a societal perspective. And the model we've pursued is a model which shows this tension between moving from a diagnostic model to a therapeutic